Right. Well, good morning, everybody, or good evening, depending upon where you live. Today, we have the pleasure of having Ostap from Ivano-Frankivsk in Western Ukraine, who's going to give us a little lecture on facial nerve schwannomas. Um, and he's an ENT doctor in Western Ukraine. He's fairly young and is getting a lot of experience at the hearing center in his town. He works with Roman Fischuk, and we're pleased to have him here today to give us some information on this facial nerve schwannoma. Thank you, Oscar.
Okay, I will start. Okay, can you see my screen and the pointer as well?
Everything's good, thank you.
Okay. So today we will talk about the facial nerve schwannoma. That's a benign tumor of the facial nerve, and it's quite rare tumor comparing to the vestibular schwannoma. And I understand that when I looked at the epidemiology of the facial nerve schwannoma, because there's not many information about this. So there was one large study. So they examined 600 temporal bones, and they found that the incidence of intratemporal facial nerve schwannoma was 0.8%. It consists of less than 1% of all temporal bone tumors. And the one thing is important is that you should keep in mind whenever you see a patient with facial paralysis, that 5% of all facial paralysis cases could be due to the facial nerve schwannoma. And it is important because you should always rule out this type of tumor if you see the patient with any type of facial nerve disorder. Comparing to the vestibular schwannoma, which we all familiar with, and I believe that all ENT doctors, even general ENT, they see at least one vestibular schwannoma at some point of their practice. And the recent studies, they actually showing that the incidence of the vestibular schwannoma is increasing. So the average is 11.5 cases for 1 million inhabitants per year. And in the last decades, it looks like it's increasing and could be up to 17.4 cases of vestibular schwannoma for 1 million per year. Probably because now we have a better MRI scans, we have better resolution on the CT scans, and it's more available, and usually people will perform the MRI scan for other pathology, and they will incidentally find that they also have some lesion at the area of the CBA angle. And at one study that Richard sent me that I used to prepare for this lecture, they actually reported 6% of people diagnosed with facial nerve schwannoma, and it was incidentally when they did a regular MRI scan for other pathology. Now I will talk about the epidemiology, the clinical presentation, and also some features that we can, how we can make the diagnosis by talking and examining the patient. And I compared two large studies. One, Matthew and colleagues, they review 80 cases. It was published in 2016. And another study was done in 2008. That's by McMonagle and colleagues, and they published 53 cases. Looks like the males and females in one study, the males outnumbered the females, but generally it looks like almost between 50-50%. The mean age was 47 years old in one study and 49 years old in another study. And the age, it's actually between 5 that's the youngest patient, and 84 years old, that's the oldest one who was diagnosed with this type of tumor. The most common clinical symptom was actually the facial nerve weakness, but still you can see that the Hals-Breckmann 1, which is completely normal function of the facial nerve, was in 68% of patients in one study, and almost half of patients in another study. And also we have almost every third patient presenting with some type of facial nerve disorder, ranging from the Hals-Breckmann 2 to the Hals-Breckmann 6, which is the complete facial nerve palsy. In one study, and almost 50% in another study. Looks like the Hals-Breckmann 2 and Hals-Breckmann 3 is the most common damage to the facial nerve, and we also have more people having a complete facial nerve palsy in comparison to the Hals-Breckmann 5. There's also some other symptoms that was quite common in patients with facial nerve schwannomas. The hearing loss is probably the second most common complaints. We have 54 people in one study and 58% in another study with some type of hearing loss. The majority of those people, they have sensorineural hearing loss. Some people, it's definitely much less, they have a conductive hearing loss. And in one study, they reported also 5 people with the mixed hearing loss. So the sensorineural hearing loss is actually expected, because if the vestibular if the facial nerve schwannoma at the area of the internal auditory canal, and when this tumor is expanding, it also will compress the vestibular nerves and also the auditory nerve, and that's how the hearing loss, especially the sensorineural hearing loss, is occur. The cases with the conductive hearing loss is usually when the tumor at the area of the tympanic segment of the facial nerve, and it can cause the erosion of the ossicles, or it can cause the mass effect in the middle ear, and by causing the conductive hearing loss. Also, the tinnitus was quite common, almost 40% in one study, and about 25% in another study. The dizziness was reported in one study is almost 40%, and another study they reported the vertigo, imbalance, ataxia, and it was almost 25%. And usually people with the facial nerve schwannoma, they will have some type of facial numbness, or it could be the facial spasm, facial tic, twitching, formications, or synkinesis. I believe that those are quite specific for to suspect any problems with the facial nerve. Okay, and those are some pictures of the facial nerve schwannoma. You can see during otoscopic examination, especially if this tumor is located at the area of the tympanic segment, or maybe the area of the mastoid segment, if it's actually expanding and causing. On this first picture, we have the left ear, and we can see that the tympanic membrane is displaced laterally. We can see there's some mass behind the ear in the posterior quadrants. And on this picture, the picture B, we can see there's also some mass at the area of the internal of the external auditory canal, and also in the posterior parts of the tympanic membrane. So the general rule, if you're not sure what it is, it's never biopsy this area because you can cause a facial nerve palsy just by performing this a simple biopsy. So it looks not right if the clinical presentation is not just a simple otitis media or any effusion or any else symptoms. It's probably better to perform the CT scan, MRI, or even both, and rule out the facial nerve tumor, and then make a decision should you biopsy this lesion or not. And when we are talking about the workup, it's definitely we should start with the radiology. We should order a CT scan, the MRI scan. The CT scan is good for approaching and evaluating the tumor in the intratemporal area because we can see and appreciate the fallopian canal and the tympanic and mastoid segment. And when we are talking about the facial nerve schwannoma at the area of the CPA angle, we should go for MRI scan. And I will show you some pictures of the facial nerve schwannoma, both on CT scan and MRI, and we will have a short summary at the end. So this is the coronal view, and we can see there is some soft tissue mass in the area of the labyrinthine segment of the facial nerve. And also we can appreciate that there's some erosion between this mass and the cochlea. Picture on the right side, that's the same patient, and we can see again the soft tissue mass here in the labyrinthine segment. And there is also some expansion of the area of the tympanic segment of the facial nerve. And here we have, that's the axial view, that's the left ear, and we have the mastoid segment of the facial nerve. We can see that the fallopian canal is enlarged. There is some soft tissue mass. We can see any bony destructions that is very common in case of malignant tumors or metastasis of other tumors into the temporal bone. And that's this like nice, smooth margins should us, probably we should think about the facial nerve schwannoma in this case, especially in this mastoid segment. And that's the coronal view, the same patient, and we can see again a soft tissue mass in the mastoid segment without any bony destructions around. Okay, again, CT scan. There is some soft tissue mass on the left side, in probably at the area of the geniculate ganglion, and also the tympanic segment of the facial nerve. If that could be the head of the malleus, then we can also see that this mass is compressing on the head of the malleus. And here we have the same patient. That's the axial view, and we can see the tumor in the area of geniculate ganglion, the tympanic segment. Here we have the head of the malleus and the body of the incus, and the tumor is actually compressing liquid on those structures. So probably in this patient we can see some type of mixed hearing loss or conductive hearing loss on audiometry due to the decrease of mobility of these two ossicles. And now we have the MRI scan, which is also very useful for detecting facial nerve schwannomas. We can see the right side lesion, which is hyper intense comparing to almost probably just the part of the facial nerve that is completely normal on the left side. Here we have the coronal view. Also, we can appreciate this lesion. And in this case, because the tumor is located in the mastoid segment of the facial nerve, the sagittal view is very useful, and we can see the mastate segment of the facial nerve. Here we can appreciate the part of the tympanic segment, and we can see how this lesion at the area of the mastate segment is actually hyper intense compared to the normal facial nerve above and below this lesion. And on the left side, we can see just the normal facial nerve and how this lesion is hyper intense compared to the normal tissue of the facial nerve. Also, the very useful T1 weighted images with the contrast. The gadolinium is mainly used for detecting facial nerve schwannomas and other schwannomas as vestibular schwannoma. And here we can see the tumor at the area of the CPA angle, and also it's coming, looks like it's coming from the internal auditory canal. And here we can see a large lesion at the area of the middle fossa here. It's hyper intense and looks like it's like the heterogeneous lesion, which is common for large lesions. So there is some inclusions in the middle of this lesion. Another MRI scan, that's a really nice scan. You can see the left side, the internal auditory canal, and here we see some lesion at the labyrinthine segment of the facial nerve. That's the lateral semicircular canal, that's the superior canal, and here we have the lesion. And that's the coronal view, that's the axial view, and here we can see the lesion. So that's a short summary for CT scan, MRI scan, and what we should look when we're suspecting a facial nerve phenomena. So both on CT scan and MRI, for small tumors, they usually homogeneous, they show the homogeneous enhancement. If the tumor is large, they will usually show a heterogeneous enhancement on both the CT scan and MRI. And what is very common for facial nerve phenomena, it's the multiple segment of the facial nerve involved. So if you see a tumor, especially at the area of the geniculate ganglion, that also expand to the tympanic segment or to the labyrinthine segment, that's a very high suspicious of the facial nerve phenomena. What's specific for CT scan? As I mentioned, the region of the geniculate ganglion involvement, and we can see it's called the signet ring sign, and that's how the signet ring looks like. So the geniculate ganglion area is large, and the labyrinthine segment and the tympanic segment showing less enhancement. The fallopian canal expansion on CT scan and the otic capsule erosion. That's what we should look if we suspect the facial nerve phenomena. On MRI scan, on T1 images, the tumor is it could be iso to hypointense in comparison to the brain tissue. On T2 images, it's typically hyperintense, and the T2 with the contrast, it's homogeneous enhancement for large tumors. And there's some type of tumors, the facial nerve phenomena, when there's a cystic component. So we can see the low signal at the area of the cystic component. What's the challenge for MRI scan and CT scan? Is probably when the tumor is located at the CPA angle or at the area of the internal auditory canal. And if that's the case, we can misdiagnose and suspect the vestibular schwannoma as a much more common lesion instead of suspecting the facial nerve schwannoma. And the same when the tumor in the parotid gland, because there's a lot of benign tumors like adenoid cysts and some other malignant tumors at the area of the branches of the facial nerve on the at the area of the parotid. That it also probably not the first diagnosis when we see something in the area of the parotid. Also, very interesting is the topic of the tumor location. Again, those two studies, and looks like the area of the CPA angle was, oh, no, the area of the internal auditory canal was the most common, was 48% in one study and 43% in another study. As I said, the labyrinthine and geniculate ganglion segment was also very common, with 40% and almost between 37 and 45%. Then what's probably specific for facial nerve tumors, that's the tympanic segment and the mastic segment, almost every third patient. Between 15 and 23%, this tumor is located at the area of the parotid gland, and there's some small percentages for tumors located at the area of the GSPN and the stylomastoid foramen. As I said, usually those tumors involve more than one segment. And in this on this table, we can see that between 74 and 80%, more than one segment of the facial nerve was involved. The average was 2.5 segments, and only about 20% to 26% the tumor was located in only one segment. So the geniculate ganglion area is number one, labyrinthine segment also very common, and what's specific, those segments are very common for the facial nerve, and there is not many other lesions that can involve those segments. What else we can do? The biopsy, as I mentioned, it's contraindicated unless some malignancy is suspected. But you should think twice before performing the biopsy. All the articles, they usually show that the result was the facial nerve palsy or the facial nerve paresis after this biopsy. Electroneurography. It's not commonly used, but it could be of great help, especially when you follow up the patient. You can assess the level of degeneration, because with the House-Breckman scale, they probably can progress much more slowly, and it's hard to follow them from one visit to another visit. And some studies, they suggest if you on this ENG, you see that the level of degeneration is about 50%, you should think about surgery, because the sooner you will go for surgery, the better facial nerve function you can achieve. What's the treatment options we have? One is observation, another is radiation therapy and radiosurgery, and the last one is surgery. And we quickly will talk about each of this. So the first, the very popular one is observation. In other words, wait and scan approach. And in this approach, we have a lot of questions that we should try to give the answers for them to understand what's the next step will be. So we all think about the size of the tumor, because studies showing that the larger tumors, they have a tendency to grow, and usually they grow faster than the small tumors. Not all tumors are growing, so definitely less tumors are growing, but the average speed will be around 2 millimeters per year. We should also assess the initial House-Brackman score because if we're planning surgery and if the surgery will be the total tumor resection with using the graft to repair the facial nerve continuity, the best result we can get will be between the House-Brackman 3 and House-Brackman 4. So I'm not sure that that's a good idea to jump into surgery in patient with House-Brackman 1 or House-Brackman 2, because you the best result you will get is probably the House-Brackman 3, and in those cases with a good facial nerve function, you can observe those patients and see how they will look in a year or 2 years, and see if this facial nerve function is decreasing through this period. And also the patient choice. Uh, what's the lifestyle of this patient? Is it important for them to have a normal facial nerve function? If the job they are doing is related to the communication, maybe they are actors and people that actually making money by using their faces. Uh, Also, the health status of those patients, because not all patients are suitable for surgery if they have a poor health condition, if they older and have other pathologies, especially chronic diseases. Maybe the observation could be the only suitable option for them. And those some results for studies done is observation. So one study, they observed 10 patients, and 8 patients, they show normal facial nerve function and no signs of radiological growth. Another study was 21 patients, and 70% of them, they have a between House-Brackman 1 and 3, and the follow-up period was 6.4 years. Another option is radiosurgery, and the results are very promising, but there's definitely not enough data to make judgments. But you can see that the tumor control achieved in about 90 to 93% in all 3 studies, and also the facial nerve function. The results are also very promising because only between 9.5 and 13% they show a decline of the facial nerve function after radiosurgery. There was also some improvement in 21% in the first study and 19% in another study. And also the hearing function. And those people with the hearing function at the time of presentation, we can see that the hearing get worse from 4 to 36% in those who received radiosurgery. And this is another study. They have 13 patients, and they did the radiosurgery, mainly the stereotactic surgery and CyberKnife. And you can see the House-Brackman before surgery and post-surgery, and looks like in most cases it remains the same. There's one patient that was the House-Brackman 2, and then after radiation, the patient jumped to House-Brackman 4. And also you can see that the tumor control they achieve in most cases, they achieve the tumor control. And look at the follow-up period. That's the 60 months, 58 months. So that's a long time for follow-up. And now we will talk about the surgery. The first, what we should consider is the approach. We can have a lot of approaches for this type of tumors. That could be the middle fossa approach, the transmastoid, translabyrinthine, transotic, transcochlear, retrosigmoid, and transparotid. So mainly we assess the tumor and we plan the approach based on the location of the tumor, the size of the tumor, the hearing function. So if there is some hearing and tumor at the area of the labyrinthine segment of the, or at the area of the tympanic segment, maybe the middle fossa approach is a good option for these patients to preserve hearing. If the patient present with a dead ear, then we can go and use the translabyrinthine approach. And in this area, in this approach, we have a very good access to the tumor, and but in this case, we sacrifice the hearing function. And there is also a debate between the gross total resection and subtotal resection. So I looked at some articles and tried to find some pluses and minuses in both of this operation. So the biggest plus in the total resection of this tumor is actually we resect the segment of the facial nerve, and we don't have tumor, and there's no residual tumor. But the minuses is uh, we the nerve reconstruction required. The best result that we can achieve that will be between Hausbreckman 3 and 4, and usually this rehabilitation period is much longer in case of the subtotal resection. So after surgery, the patient will have a Hausbreckman 6, and they fortunately will get better between 6 months and 1 year to the Hausbreckman 3 or Hausbreckman 4. There's the cases with subtotal resection. The biggest plus is that we preserve the facial nerve function. One study showed that the post-operative Hausbreckman was 1.5, but there are some minuses, and usually those minuses are associated with residual tumor, the chances of tumor regrow, the chances of having additional surgery, and and also the limited application of this operation, because not all tumors we can do the subtotal resection, and there's much less cases reported of subtotal resection comparing to the total resection of the tumor. And when we perform a total resection, we should, in most cases, it's very hard to approximate two segments of the facial nerve. So we usually use some type of the graft, and we put the anastomosis between two segments of the nerve. What the graft material we can use? We can use the greater auricular nerve, which is probably more commonly used. We can find this nerve between the angle of the mandible and the mastate tip. So that's the line of the incision. And what's good about this nerve, that's the diameter of this nerve is very close to the diameter of the facial nerve. And also it's in the area where we perform the surgery. So we can make just one additional incision, or maybe we don't even need additional incision. We can harvest this greater auricular nerve and perform and repair with facial nerve with this material. Another option, the common option, is using the sural nerve. The problem with this nerve is the diameter of this nerve is much bigger than the diameter of the facial nerve. And also there's some, usually the patient will have a big scar at this area. There's some reported techniques of endoscopic harvesting of this sural nerve, but that's not very common. And here's the intraoperative picture of the nerve graft and two parts of the facial nerve repair. Another option, that's probably when you, that's probably a last resort, when you remove the tumor, you perform repair with one of these types of grafts and you're not seeing any positive result after 6 months or after 1 year, then you can perform a transfer surgery and suture the facial nerve to the hypoglossal nerve transfer. Usually those patients will have the same, usually they will have the same result as after the total resection, the House Brackman 3 or 4, but one possible complication is the hemiglossal atrophy because we cut the hypoglossal nerve here. There's some type of conservative surgery, not very common. The first one is the facial nerve decompression, and looks like the study showed that the House Brackman score improved from 2.6 to 1.6. And in some cases, when we have a tumor with a cystic component, we can perform the drainage of the cyst. And some studies, they reported up to 4 procedures when they constantly drain the cyst to preserve the facial nerve function. That's all. That's all. So if you have any questions, also there's some doctors that joined our meeting. So if someone have experience with the facial nerve schwannomas or other facial nerve tumors, I would like to invite you to share with us your experience because those are very rare tumors. I know that Richard has some experience. Maybe Richard will tell us something about facial nerve tumors. And
what's interesting is that in cadaver studies, they had 5. It was 0.83% in 600 patients, which is about a little more than 1 per 100. And in otosclerosis, they found in cadavers almost a 1%, as well. But yet, from a clinical point of view, we only see symptomatic people with vestibular schwannomas in about 1 to 100,000. I don't really know what the clinical incidence is of, of facial nerve schwannomas. So that's a question I still think that hasn't been answered. We know what it has been in cadavers. The other thing is when you do an otoscopy, and you mentioned this, one of the images looked very much like acute otitis media, and you have to be careful. Again, you're not going to, the incidence of acute otitis media in an adult is very rare. So, unless they have a history of upper respiratory infection and pain, and if they've got that's one scenario. But if they present with a conductive hearing loss and a mass like we saw on otoscopy, you've really got to think a different pathology. Finding facial nerve schwannoma in a child is much more rare. The other thing about MRI, if you have the lesion from the cerebral and pontine angle to the labyrinthine segment, okay, if the tumor goes into the labyrinthine segment, that's going to most likely be a facial nerve schwannoma. You don't usually see vestibular schwannomas going into the labyrinthine segment. So that's kind of like one little clue. The vestibular schwannomas much more common at cerebral and pontine angle, the meatal segment. The other thing was the use of gadolinium. It's difficult to differentiate facial nerve schwannomas on MRI from a vestibular schwannoma, but because on T1 without contrast and then just a regular T2, you might see a little enhancement on the T2, but with the gadolinium on the T2, you really pick it up. Um, the other thing, which article that you showed some information on one slide about radiotherapy, or excuse me, radiosurgery. What article was that from?
One was from Japan, and
Okay, maybe you can send it to me later. Okay.
mhm.
Okay. And then the other thing is your slide on location. It looks like, can you go back to that slide? Because it looked like the percentages or the number of people didn't match the study number. It was a really nice chart. Can you go back there for us?
Just 1 second.
That's the chart. Yeah. See, I mean, like in Matthew's study, he's got 80 patients, but you've got like 200% here.
Oh, but because they reported that usually more than one segment was involved, so they, if like 2 segments was involved, they give
They
one
included
patient.
in both areas. Okay.
Mhm.
That's a little deceiving. So I think it'd be better to show that, the most common area that the facial nerve schwannomas is basically the geniculate ganglia, followed by labyrinthine and probably tympanic segment accordingly. Um, it's just a little, it's a little,
Distracting from.
it's a little it's a little hard to understand it. Okay. That's all I'm saying. Okay, I think there might be a better way to present it. Okay, otherwise, I thought the lecture was really good. It covered everything you pretty much need to know. Um, Anybody got any questions for Oscar?
Richard.
Yeah, hi, Jorge. Jorge is from Asuncion. He's the director of the Otology Fellowship Program.
Sorry, Richard, I can't speak in Spanish, but my English you know very well.
Si quiere hablar en español, dígame, yo voy a traducir.
Yo tengo un caso como experiencia personal hace 10 años atrás o 15. Lo que quiero dar importancia es que a veces se presenta como un pólipo en el conducto auditivo externo y no todo pólipo es colesteatoma.
Entonces era un pólipo con colesteatoma, pero era una...
No, el diagnóstico se entró con una sospecha de otitis media crónica colesteatomatosa por la presencia del pólipo.
Okay.
La anatomía patológica vino Schwannoma.
Okay, so
el paciente nunca tuvo parálisis facial, ni después de la anatomía patológica.
Y después de la biopsia tampoco.
Tampoco.
Okay, so Jorge in Asuncion had a patient about 10 or 15 years ago. He's had one patient with vestibular schwannoma. The patient did not present with facial paralysis. The patient did present with a polypoid mass in the ear canal, which clinically, I believe he said looked like an ear canal polyp, but they did biopsy it. The patient did not develop any facial paralysis, and it came back facial nerve schwannoma. Okay.
Le volvimos a operar porque volvió a crecer el pólipo y por la extensión de la lesión y conociendo ya el diagnóstico, optamos por una cirugía radical con timpanoplastia. Bueno, una timpanoplastia abierta. El paciente evolucionó favorablemente. El último control fueron 4 años después y con buena evolución.
Sí, pero tiene que cortar todo el nervio facial, ¿correcto? Y tiene
No, y no tenía adherencia. La porción horizontal o timpánica estaba libre. La adherencia principal estaba en región posterior, en la región retrotimpánica, pero el nervio facial no aparentaba estar envuelto por la patología y sospechamos que pueda haber aparecido de un ramo colateral del nervio facial.
y the cord of the tympani?
Corda del tímpano.
Okay, so basically what happened is they did a resection on this patient. The facial nerve was all intact. So this facial nerve schwannoma, they believe, could have come from the cord of tympani or another small branch from the facial nerve in the middle ear. So they did a resection and removed the schwannoma, but the facial nerve remained fully intact. Very interesting case. Un caso muy interesante. Tiene que escribir un artículo sobre esto.
Ya escribí y voy a compartirlo con ustedes. Ya lo publiqué.
Está bien. Pone en WhatsApp, okay?
Okay.
So
thank you for Ostap for the lecture. Very interesting for us, for me. Okay, only that.
Ok, Jorge, muchas gracias y poner el artículo en el WhatsApp para compartir con el resto del grupo, ok?
Okay.
Okay, so Oscar, so Jorge is going to send us and put on WhatsApp a copy of the article he wrote on that very interesting case, okay? Does anybody else have any questions? Lecture was well presented, good video. I mean, good visualization. Slides were very comprehensive, other than that one slide, which was a little deceiving. And we appreciate your time and efforts that you put into it. I'm not sure how long it took you to prepare it, but Jorge just gave us the connection there. Okay, if nobody else has any questions, I'd like to thank Oscar for his time and patience. And we'll look forward to seeing you next week. We're still trying to get a lecture scheduled. I believe that that Jose Lovera from Asuncion will lecture to us next week. And for everybody, stay safe, COVID-free, and take care of your families, okay? Thank you, everybody. Thank you, Oscar.
Okay, bye. Thank you. Have a good day.